Let's consider the question, how much of a drug do I need to give in order to rapidly reach a target plasma concentration, which will be denoted by the C sub P, at steady state? So, to figure this one out, we need to look at the loading dose. Now, the loading dose is going to be equal to the plasma concentration, so our target plasma concentration, or CP, times our volume of distribution, times a dosage interval, which I'll express as a little t, divided by bioavailability. The goal of a loading dose is to give a bolus of drug in hopes of reaching a target plasma concentration, or CP, as quickly as possible. So let's dissect this equation down. Now, we have the plasma concentration being our CP of a particular drug in the plasma. Now, if we want a large amount of a certain drug to be in the body, we'd give a larger loading dose. Now, since the plasma concentration is found in the numerator, a larger target dose would mean a larger loading dose. Same with volume of distribution here. A higher volume of distribution means you need to have more drug to cover this larger distribution area. So a larger loading dose is needed. So if a drug spreads out to a larger area of the body, you'll need a larger loading dose to concentrate it within a certain area. A higher dosage interval means that you need more drug, or else levels will get too low before you give more. And lastly, we divide by bioavailability, because not all drugs are going to be utilized in the body at 100%. Remember, IV drugs skip the first pass effect, so IV bioavailability is always 1. However, the bioavailability for drugs by mouth is less than 1, typically. If only 50% of the drug that is given is actually utilized before it gets metabolized, the bioavailability of that drug is 0.5. So dividing by 0.5 actually doubles the loading dose, so twice as much drug should be given, since up to 50% of that drug will be cleared by the first pass effect. Now, what about the question, we just gave a patient a loading dose of a drug. Now, how much of the drug do I need to keep giving in order to keep the patient at the target plasma concentration? Now, the answer is going to be given via the maintenance dose. Now, for a constant IV infusion, maintenance dose is equal to the plasma concentration, or our C sub P, times the clearance, times our dosage interval, divided by our bioavailability. Now, note how the maintenance dose is going to be dependent on the clearance, while the loading dose was not. The loading dose was dependent on the volume of distribution, while the maintenance dose will now be dependent on the elimination, or the clearance of the drug. So, in patients with renal and liver disease, they may have impaired clearance. They're not able to get rid of the drug as fast. So the maintenance dose will need to be adjusted. Now, in people with liver and kidney disease, the loading dose is not going to be factored in, because remember, the loading dose did not have clearance. However, for the maintenance dose, you'll need to adjust it. You'll need to give a smaller maintenance dose. Now, why is this? Because when you have renal or kidney disease, you can't clear the drug as fast, so more drug will stay in the body. And if you have more drug staying in the body, smaller doses will be required to maintain that plasma concentration of the drug, the C sub P. Now let's try a tough practice question. A new antihypertensive drug is being tested in clinical trials. A 20 milligram IV bolus of the drug is given to a poor medical student volunteer, and the graph shown here is going to illustrate the results and show the decline in plasma concentration over time. So, before we begin, let's take a look at the graph here. We have the x-axis in hours, where each interval is 10 hours, and the y-axis is our plasma concentration in nanograms per milliliter. Also note how we have a log scale. It's not a nice even scale. Here we have a log scale, so this would be concentration 0, maybe 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So remember, log scales do not follow the nice even spacing as such as the x-axis down here. Alright, so based off of this, what approximately is going to be our half-life. Notice here, at time 0, we're going to have a plasma concentration of about 80 nanograms per milliliter. Now, just as a disclaimer, I am going to leave off a lot of units on this page, and that's because it can get a little messy with all the different units. However, I will simplify it down for you. I'll do all the math for you, and I'll leave some units on, but for the most part, I'll leave units off. So our initial plasma concentration at time 0 is going to be 80. The half-life implies that this 80 will turn into a 40. Now, our 40 will be approximately right there. Why do I say there? Remember, it's the log scale where here would be 20, 30, 40, 50, 60, 70, 80, 90, 100. Okay, so we're trying to get to 40. How long does it take from our plasma concentration to go from 80 nanograms per milliliter to 40 nanograms per milliliter? Well, let's trace this over. Oh, shock. A nice even number. The USMLE will give you nice even numbers in most cases, because that makes mental math a little easier. You don't have to use the calculator. So to get to a concentration of 40, it takes approximately 10 hours. 10 hours to have our plasma concentration. That's the definition of the half-life, so it takes approximately 10-hour half-life. Alright, let's take this a little bit further. What is going to be the volume of distribution in this case? Now, the initial plasma concentration is going to be 80 nanograms per milliliter. Now, our volume of distribution is going to be equal to the amount of drug in the body. So our dose, we gave 20 milligrams of drug. 20 milligrams divided by our plasma drug concentration, which is 80 nanograms per milliliter. Now, I'm just going to simplify the units for you. This is equal to 250 liters. Now, notice that since the drug is given intravenously, the bioavailability is going to be 1 and therefore can be neglected in our calculations. However, what if the drug was given orally with a bioavailability of just 50%, if our F was 0.5 or 50%? Then how would that alter our calculations? Well, if our bioavailability is only 50%, it means only 50% or half of this 10 milligram IV infusion actually made it to our target area. So that 20 would turn into a 10. So it's the top number, the numerator, times our bioavailability, or 0.5. So it would be 10 divided by 80, which would give you 125 liters. But for our instance, just remember that our volume of distribution, given an IV bolus, which has a bioavailability of 100%, is going to be 250 liters. Okay, so what is the rate constant of elimination? Well, remember our rate constant of elimination is our Ke. Remember that's equal to natural log of 2 divided by half-life. Okay, so natural log of 2 can be simplified to 0.7. 0.7 divided by our half-life, which was 10 hours. So yeah, we're kind of painting a picture now. Our half-life is 10 hours. 0.7 divided by 10 is 0.07 hours to the negative 1. Alright, so that's our rate constant of elimination. So that brings us into our question about what is the clearance. Well, remember the clearance equation. Clearance is going to be equal to our Ke. Well, that's convenient. We just did that. Times our volume of distribution. Check that one off. Well, this will be a nice easy one. 250 times 0.07, remember I'm leaving off units here, is equal to 17.5 liters per hour, or it's going to be equal to 292 milliliters per minute. Now, again, I'm not going to show you the conversions. There are unit conversions. I'm just going to give you simply the answer. So 292 milliliters per minute. That's our clearance rate. So now let's infuse a drug at a rate of 0.5 milligrams per minute. What will the steady state concentration be? Now, to answer this, we'll need to remember that for constant IV infusion, the maintenance dose, which I'll label by M, is going to be equal to Cp, the plasma concentration, times the clearance of the drug. Now, we want to know the plasma concentration at steady state. So what we can do is we can divide the clearance over here to rework the equation. Maintenance dose divided by the clearance is equal to our plasma concentration. Well, our maintenance dose is 0.05. Our clearance, we just calculated, was 292 milliliters per minute. Remember, I'm leaving off units. So 0.05 milligrams per minute divided by 292 milliliters per minute. That will give us a steady state concentration of 0.17 micrograms per milliliter. Okay, so 0.17 micrograms per milliliter. Now what happens if we double the infusion rate? If we double the infusion rate, so we turn 0.05 milligrams per minute into 0.1 milligrams per minute, what is going to be our steady state concentration then? Well, our steady state concentration would be 0.1 divided by our clearance. Well, that simply just doubles our steady state concentration. So 0.17 turns into 0.34 micrograms per milliliter. If you double the infusion rate, you simply double steady state concentration. Alright. Lastly, how long would it take to reach the steady state plasma concentration for each of these two infusion rates, the 0.05 and then if we doubled that? Now, before we start writing out equations and making calculations, let's take a step back and think about this question and what it's asking. Both infusion rates are constant, even though one is twice as fast as the other. Now, with what we've covered earlier, a drug infused at a constant rate takes 4 to 5 half-lives to reach the steady state. It really doesn't matter how fast we're actually infusing it. It's going to take 4 to 5 half-lives to reach steady state. So this is going to be an important thing to remember. Now let's take a quick mental break. I've been in your shoes, and the studying for boards is tedious and boring work. Now, I feel your pain by now. You're probably slumped over your computer with a neck ache. You're tired of sitting there looking down at your computer. But someday, you will look back and realize that all of this time studying for boards will have paid off. So hang in there, because I'm here to get you the maximum pointage on your USMLE. So now we're a little over halfway with the pharmacokinetic and pharmacodynamic portion of pharmacology. We dove into the deep end right away. We covered some important concepts. The material that we've discussed doesn't have much memorization, but more conceptual concepts that will be important for test day. Right. So the nice break is over. I'm sorry. Let's hop back to it. So now let's talk about the elimination of drugs. In zero order elimination, the elimination of a drug is constant regardless of the concentration of the drug in the body. A constant amount of drug is going to be eliminated per unit time, resulting in a nice linear decrease in plasma concentration. So here we see that nice linear decrease. So for example, aspirin in the body would be eliminated at a constant rate via zero order elimination. Now, it wouldn't matter if you took an 81 milligram tablet or a couple 325 milligram tablets, since the elimination of aspirin is at a steady pace. Now, zero order elimination is less common than first order elimination, which we'll talk about next. Since you're experts on zero order elimination now, what drugs are going to follow this zero order linear pattern? Now, there's three main ones that I want you to remember that are going to be high yield drugs for test day. These are going to include phenytoin, going to include aspirin, and it's going to include ethanol. Now, these can be remembered by the simple mnemonic P. Now, you're probably like me. When I was a kid, I ate 0 P's, and P's kind of look like the number 0 as well. So P stands for phenytoin, ethanol, and aspirin, PEA. So those are the three drugs that I want you to remember for zero order elimination. Then next, we've got first order elimination. The rate of elimination is going to be proportional to the concentration of the drug in the body. So a constant fraction of the drug is eliminated per unit time, resulting in an exponential plasma concentration. So here you see a nonlinear graph, an exponential graph. So simply put, for first order elimination, if there's more drug in the body, more drug is going to be eliminated. If there's less drug in the body, like down here, less drug is going to be eliminated. So note that the plasma concentration curve is not linear in first order like it was in zero order. Now, most drugs are going to be removed from the body by first order elimination. Zero and first order elimination can be thought of kind of like the tortoise and the hare. You remember that story when you were a kid, the tortoise and the hare? Zero order elimination is going to be the tortoise, and it's going to run a nice, steady race. Regardless of the amount of drug in the body, the tortoise will run its nice, consistent pace. Now, first order elimination, on the other hand, is the hare, or the rabbit, who runs an inconsistent race by running fast sometimes and running slow sometimes. If there's a lot of drug in the body, the hare will run faster, and if there's not much drug in the body, the hare is going to run a little bit slower. Now let's cover how drugs are cleared by the kidney. The key area here is going to be the glomerulus. Now here's our picture of the nephron. Here's going to be our glomerulus. Now, thinking back to physiology, which kind of molecules can cross the cell membrane the easiest? Do you remember? It's going to be the small, nonpolar, neutral particles. So remember that nonpolar, small, neutral particles can cross the cell membrane. So we got our phospholipid bilayer here. Okay, and it's that one wants to disappear a lot. And it's going to be that small neutral particle that is going to be able to cross. Now, the same principle is going to regulate drug reabsorption once the drug is filtered through the glomerulus. Now, drugs are going to enter in the lumen, and they're going to be reabsorbed. Now, as you'll see in the renal section, the brush border cells lining the lumen of the nephron will try and absorb any filtered drugs. So if it gets filtered through the glomerulus, the kidney is going to try and reabsorb those drugs. However, ionized species, or charged particles, are going to get trapped in the urine, and they're going to be quickly cleared because their charge is going to prevent them from crossing the plasma membrane here. So neutral molecules can be reabsorbed across the tubules. Therefore, we can use this clinically. If a drug needs to be cleared quickly from the body, the urine pH should be adjusted so the drug becomes trapped in its ionized form and then eliminated from the body. Now let's use this and take it a little further. Weak acids, such as tricyclic antidepressants, methotrexate, and aspirin, are ionized in basic urine, as shown in the following equation here. Now, why would we give a basic compound to treat a weak acid overdose? So if we have an overdose of aspirin, for example. So here's our weak acid. It's going to be lipid soluble. While the ionized form, here's our ionized negative charge, becomes trapped within basic urine. And then we can eliminate it from there. So this is why overdoses of drugs that are weak acids become trapped within the urine and are treated with bicarbonate. And that bicarbonate is going to create more ionized form. Now, we can talk about weak bases. Weak bases are going to include amphetamines. Now, weak bases become ionized in acidic urine, as shown in this equation here. Now, here, weak bases become trapped in the ionized form. Here's the positive charge, weak bases. Here's our weak base, for example. It can be trapped in its ionized form, which will eventually be trapped in the urine and eliminated from the body. So here, the bases are lipid soluble in weak base form. So if you give ammonium chloride, it's going to be used to treat an overdose with a weak base, because this will create the ionized form and become trapped.